And thanks to OPR for the invitation today. I know there are many things competing for your time and attention today, so I really do appreciate the opportunity to share some very recent work with you. I think this does speak to current events. In fact, I'll be presenting on some work some data that have just come out of the field yesterday. I think was our final day officially. And it's related to COVID and follows up on a data collection effort that Matt had mentioned already. So this is very preliminary work and consistent with the funding mechanism. We're disseminating this at a very preliminary stage and hope to get some useful feedback. This is a great audience, and I'm sure that we'll really benefit from having some feedback at this, again, very early stage. So I'll just pull this up here, share screen. Okay, so hopefully everyone can see this. Just as by way of background, again, this is a follow-up from the ongoing Adolescent Health and Development and Context study. We began that back in 2014. Did 2 waves of data collection, focused on everyday exposures of youth and the activity spaces they encounter and how these are relevant for health and development. And we then received some follow-up funding to pursue a 3rd and 4th wave, focused on a subsample of these kids, linking a similar design with respect to measurement of exposures based on smartphone, EMA, and GPS, linked with fMRI data. So that was a smaller subgroup of the original sample. We began that in 2019 and then hit the pandemic. We got fairly far into the data collection. A little over 300 kids did participate in that study, but we didn't get to our final sample size, unfortunately. So at that point, we pivoted to COVID to try to understand how our kids were adapting, principally with respect to mobility and social distancing, since that aligned with the original focus of the study. And began that COVID-specific supplement in the middle of the summer. And again, just got out of the field. Of course, the field period lasted a couple months longer than we thought it would, but that's just the nature of data collection. I guess I should know that by now. In any case, again, very preliminary. And what I'll focus on today is the now well-established racial disparity in infection risk. And this has been documented in adults to a great extent. That's been evidence of that is pretty consistent at this point. The evidence on youth is emerging. But the emerging evidence does suggest that the racial disparity in infection risk is replicated for that population. So in a recent study, I think published the last couple of weeks in pediatrics, found a pretty stark disparity in infection for children 0 to 22. So we're observing this across the life course. So then the question becomes, well, what explains this disparity in infection risk? And we think that the adolescent population is worthy of exploration in its own right, even though outcomes tend not to be as severe. They are definitely hold the potential to spread the virus within the community. So understanding their behavioral patterns and potentially greater risk exposures is important. And even moving forward as we hit this new spike. So a couple of different major emphases in the effort to explain the disparity in infection risk. First being exposure risk, which is what we will focus principally on today. And I'll get into that, what we mean by exposure risk in a moment. Another focus of attention has been pre-existing vulnerability to infection, with the major emphasis being on existing chronic conditions that make people more vulnerable to both infection and long-term severe outcomes. Some attention, but less, on elevated physiological stress and associated compromised immune system as a function of, for instance, in the Black population, exposure to systemic racism, toxic stress, everyday discrimination, microaggressions, and so on, that result in chronic stress and potentially compromised immune system on an everyday basis that could place people at greater risk of infection, including youth. In the case of youth, chronic conditions could include asthma and obesity, but I think actually the physiological stress pathway, independent of chronic conditions, probably holds more promise for understanding racial disparities. And if there's time, I can get into some of the recent work from our data that bear on this issue of chronic stress and possibly elevated risk of infection. So what do we mean by exposure risk here? So you can think about the density of social exposures. That's what we've chosen to call the major focus of attention on this. That is simply the number of people one encounters on a daily basis, how proximate one is, say within 6 feet or not, how many people at the same time one is exposed to, the duration of those exposures, and so on. That, again, is the principal focus when people discuss social distancing and so on. They're most often focused on those variables. And certainly other protective measures as well, mask wearing being the major focus, but also avoiding indoor social exposures, hygiene, and so on. Another aspect of social exposures that I think is highly relevant but doesn't get as much attention is the composition of those exposures with respect to infection status. So who around you, if you are proximate to people, is actually infected? What proportion of those people have the virus and could spread it? Of necessity, we don't focus on that in large part because we typically don't have the data on that. And certainly from the standpoint of public health messaging, it is not a wise idea to use proxies for that. It's very difficult, not very salient, to actually observe the virus among those you're encountering. So public health messaging has tended to focus on density of social exposures. That said, from the standpoint of understanding infection spread in the population, composition of social exposures is an important factor that we need to spend more time on. All right, so what about, how could we understand density of social exposures as potentially contributing to the explanation of racial disparities? And here I'm drawing on the existing literature on racial disparities in COVID. Now, there's been a huge volume of published work on COVID, some empirical, some speculation, more essay-oriented on what's likely going on. And despite the elevated rate of production of that literature, we still don't have very solid work. It's just too soon into the pandemic to have a solid body of work to really understand these racial disparities. Nevertheless, the emphasis has been on concentration of Black people in higher density urban areas. So that is fairly consistent as a possible explanation for increased density of social exposures, rooted in higher housing density, more use of public transportation, and the expectation then is that living in higher density urban areas will translate into greater likelihood of exposure to others at high levels, high numbers, and proximity at the everyday locations of activities as well. There's also been a focus on in-home conditions, household members who are employed outside the home in high-risk occupations, essential workers, and so on, who are, have a greater likelihood of coming into close contact with others, as well as household crowding. All right, so we offer what we think is some reason to question whether actually the density of social exposures would be greater for the Black population and Black youth in particular. And here we're drawing on what we think are important contributions of the urban sociological literature that have implications for understanding mobility, activity space dynamics, and so on with relevance for the pandemic. So first, population declines are more likely at higher levels of area economic disadvantage. Black populations, urban populations may not experience the everyday density, population density that is assumed, certainly by comparison with rural areas, but not within metro regions that have also been a focus of some attention. So what you're seeing here on the right is a map of population loss by census tract. This is the Columbus area, and that squiggly yellow line is the boundary of the city, which gives urban planners considerable grief in its messiness, and also for those of us who try to line up city boundaries with census tract boundaries. Nevertheless, you see there in the center, essentially a column of green areas that capture census tracts with population loss over the 2000 to 2010 period. This, as you'll see later, aligns very closely with the concentration of Black residents. This is a characteristic of urban disadvantaged areas. It's been a focus of attention since Wilson, and we think is relevant for understanding the daily experiences of urban Black residents. Relatedly, the local availability of stores and other organizations may be more limited in racially segregated neighborhoods. This goes along with population loss. This may lead to spending time at locations that are less populous, possibly also leaving the area for other organizational resources, but also potentially foregoing them altogether, leading to more limited contacts with others in the course of everyday activities. There's also some work coming out of our project on time allocation patterns among youth themselves. We find that youth living in economically disadvantaged neighborhoods spend more time at home. This is also consistent with at least the implications of the urban sociological literature, to the extent that one would expect adaptations to local conditions of disadvantage, including violence. And here we see that youth who live in the most violent neighborhoods spend about 5 percentage points more time of their waking time at home, that left set of 2 bars, by comparison with the lower violence neighborhoods. And 5 percentage points actually translates into about 45 to 50 minutes a day on the average day. So not a trivial amount of time. So these are conditions that are in place under average circumstances that may then lead to, in pandemic conditions, also if not lower, but no greater risk of exposure to high density circumstances than the white population would encounter. So that's essentially what we're looking at here, is the racial difference in density of social exposures as a key candidate for explaining the racial disparity in infection. I should emphasize that we do not have data on infection outcomes in our, at least at this wave of the COVID supplement. We have it, but it's not really analyzable. In other words, we have testing, self-reports of symptoms and so on. Those are very low prevalence at this point. There's a lot of obvious asymptomatic infection and so on. So we're not at this stage attempting to measure infection outcomes, we're looking at density of social exposures as the outcome and as a possible candidate for the explanation of disparities in infection risk. So we'll look at exposure to locations with more people present, exposure to people within 6 feet, and more frequent mobility outside the home. These are non-home exposures within the home, and the non-home exposures will be the principal emphasis. Although we're also looking at measures inside the home visitors, and then instances of other household members who work outside the home in jobs requiring high-risk contact with people. And then also less frequent mask wearing. We'll look at rates of mask wearing as well. There's also the expectation or possible expectation that by the midsummer, those residents of minority communities might have been aware of the increased risk their population faced and could have adapted with social distancing practices, possibly incurred costs in doing so, but nevertheless did so in order to lower their risk. Okay, so our data again come from the Adolescent Health and Development and Context Study, or the original sample. The sample at wave 1 was youth ages 11 to 17 within Franklin County, again focused on contextual exposures and their implications for health and development of youth. This just briefly recaps what our data collection experience has been. And you can see there we began wave 1 in 2014, wave 2 in 2016. We then began our wave 3 imaging study in 2019. We hit the pandemic in the spring of 2020 and then reorganized to initiate this COVID wave in July. I should also add, again, there will be a follow-up to this. This is not reflected in the screen here, but in January, we hope to have a second wave of this COVID supplement. And then hopefully in summer, possibly fall, we'll see how it goes, then begin our wave 4 attached to that original imaging sample, our wave 3 sample. I will draw on some of that wave 3 sample as pre-pandemic exposure outcomes that are relevant in some cases for some of the questions that we're asking here. So our study area is this kind of boxy but close to loop-like thing in the center here. That's Interstate 270. It captures both the most disadvantaged areas of the city as well as the most advantaged areas of the metro region, some very wealthy suburbs, Upper Arlington, Bexley, Worthington, and so on. So our sample captures a considerable socioeconomic diversity, both with respect to neighborhoods and youth households. Just some quick demographics on the study area. You can see here that poverty is concentrated in the center city, to some extent the Southwest. More affluent area in the northwest region of the city, higher education. The non-Hispanic Black population concentrated on the Near East side. You can see how that band down the center, close to the center of the city, just in the east side, corresponds to that population loss figure I showed you earlier. And Columbus this is a highly segregated city. Certainly visually it appears that way, and in fact, while being highly segregated, it is about average. In fact, the similarity index is right in the center of the distribution for I think the 50 largest cities. So this is not a hyper-segregated city. This isn't in Milwaukee or Chicago. Nevertheless, it's pretty segregated. So that tells you a little bit about the high end of the distribution. So the AHDC study design, what I'm giving you here is a bit of a simplification. Those features of the study design that are shared across all now four waves that have been collected. There is an entrance survey with a standard battery of social survey questions, health, demographics, and so on. We also have a network partner roster, and what we add that's something of an innovation, draws on designs, for instance, from the Los Angeles Family and Neighborhood Study, a routine locations generator, and that's for both the youth and the caregiver. And that's what we simply ask people, where do you go on a regular basis? And then we get some, not only the geographic, the XY coordinate of that location, but some characteristics of those locations. That's followed by what we call a GEMA week here. That's geographically explicit ecological momentary assessment. That's essentially just saying short smartphone surveys, the EMA component of it, and passive GPS data collection on that device at the same time, so that we can link up EMA responses to fairly precise GPS data on the immediate context. This design, again, was repeated with some variation. We used a commercial vendor in the case of COVID to capture that GPS data and EMA survey questionnaire data. That was due in part to the cost. It was far cheaper to go that route. That does introduce some design variation, though. Also, because we've just come out of the field and given the data processing requirements for GPS data, we won't be presenting that today. We'll use some proxy information to get at location, these other survey-based and EMA data to get at location-related information. So again, our COVID supplements began in mid-July, just finished. This coincided with the mask mandate in early July in Ohio, corresponding to the uptick in cases that virtually, many places in the country did experience, including Ohio. So we have an N here of about 225 youth. And again, our data in this case come from an entrance survey equivalent, which was a phone survey. It was in home on the prior waves. And then again, a smartphone week, and then a follow-up web-based survey to capture things like mental health, family conflict, substance use, and so on. And we won't be talking about those data today. So, 3 sources of location-specific data, as I mentioned, survey-based location generator information. These are all geographically referenced data, smartphone-based ecological momentary assessment, and then the GPS data, which, again, we won't get to today. So the entrance survey, that location generator I described, again, draws on prior designs that were intended to get at the locations of routine activities, where we have a structured set of places people typically go for youth, school, library, work, church, friends, relatives, houses, and so on. At wave 3, at the prior wave, we asked about each of these locations to get at the locations of these regular routine activities. We then documented those, cleaned their locations and so on, and then fed those locations back into the COVID questionnaire. So we then asked whether the youth was still going to these places, and if so, some characteristics of those locations. And then where else they were going in addition to those locations. And we asked about the last week prior to the phone interview. So for each of these locations, we have the time spent at them and various questions like how many people were around typically and so on. And you'll see some of that data. And this is just the interface. For places that have a Google address, this is a quick way of getting it. For locations that don't, we can drop a pin on a map to identify where that location is. So for this wave, our prior waves had always used project phones. And when we first started this, some substantial proportion of kids did not have a phone. And also we were dealing with some younger kids, 11 and 12-year-olds. So we went with a project phone. In this case, it was a mix. If the youth wanted to use their own phone, they could simply download the Metric Wire app and then answer EMAs, have GPS data collected on their own phone. If they requested a project phone, we sent them one. And so we had a mix. Most kids did use their own phone in this case, but some did use project phones. So this is just a screenshot of the metric wire software interface and the kind of layout that a youth might see with respect to a given question. They had 5 prompts per day. This is also consistent with the prior design. And then EMAs were administered randomly within each time block, up to about 9:30 p.m., I believe, starting at around 8. So our analytic approach here will be largely item specific. So we will take survey questions on social distancing, mobility, and so on, and do a very simple age and gender adjusted, either binary logit or in many cases ordinal logit for a rating scale. And I will present black-white coefficients for black-white differences, again, age and gender adjusted, on these outcomes. So you're getting a very preliminary take. And the approach here is to look at the overall pattern that we're observing here. Are we seeing outcomes, coefficients that are consistent with a increased risk of high density social exposures among Black youth, or evidence of no difference or even protective tendency among Black youth? So I'll begin with some general survey items. These are just traditional generalized questions on behavior from the entrance survey. I'll then move to the location generator items, those location specific questions on the survey, and then to the EMA, which gives us in the moment takes on what's happening. So our wave 3 sample is predominantly Black. It's 54% Black, which allows us to get some decent estimates, relatively decent estimates for Black youth here. I should note that our wave 3 also carried over youth from the prior AHDC sample, but also supplemented that with youth from low-income areas of the city, given the focus on exposure to violence and other forms of disadvantage. We wanted to see that effect in low-income communities in particular. So that partially explains the higher prevalence of Black youth in this sample. Within the Columbus area, it's about 28 to 30% Black. All right, so our survey-based general social distancing measures include staying 6 feet away from people the respondent does not live with. Most people did that. Wearing a face covering outdoors. Again, majority of youth report doing that. Wearing a face covering indoors. This is not at home. Again, vast majority of kids reported doing that. And then not attending gatherings of more than 10 people, majority, but less frequent. All right, so this is just a quick summary of what we get for that first set of just general survey questions. And what you see here is that Black youth are essentially no different than white youth with respect to staying 6 feet away, wearing masks inside a building, and attending gatherings, large gatherings. And they are significantly more likely to be wearing masks, to report wearing masks outdoors, generally, on those survey items. So no evidence here of higher risk exposures for Black youth. Moving to survey-based location-specific measures here. So from the data from the routine location generator, how many other people at the location when the respondent is there? And there are various categories for this. We picked these bullets here are just quick summaries, dichotomous summaries of what the distribution looks like. You're seeing on those coefficient maps, ordinal logits that take into account the whole rating scale. Here about 25% report 24 or more folks at these locations typically. how many people are, other people are within 6 feet at the location. 6+, about a quarter. How often does the respondent wear a mask at the location? Most or all the time, about 62%. Okay, here what you get is a little bit more mixed. Number of people at the location, essentially no black-white difference. Number of people within 6 feet, a higher number of people within 6 feet. Black youth report somewhat more. This is confidence interval still includes 0, but this is borderline significantly higher risk for Black youth. Although again, wearing masks, Black youth report significantly greater likelihood of doing so when asked about specific locations on the survey. All right, so both the general survey questions, in particular the general survey questions, might be subject to either recall biases or social desirability biases. So on a in-person interview, you might be inclined to report that you're doing more social distancing or more protective behaviors than you would if you had an opportunity on the EMA to report, presumably in a more anonymous way, and also in the moment. So I would argue it's a little bit harder to misrepresent what is happening in the immediate circumstance due to social desirability than it would be on a general traditional survey. So on the EMA, we ask how has R spent more than 10 minutes within 6 feet of anyone in the last hour. So a little over a quarter report having done so. Is the respondent currently wearing a mask? And are there 6 or more teens or adults around right now? So these are responses are restricted to EMAs that are answered outside the home. Here what we see is that Black youth are significantly less likely to report having spent more than 10 minutes with someone within 6 feet in the last hour. Significantly more likely to wear a mask, consistent with prior responses, and no difference in the likelihood of a relatively large number of people around, either teens or adults, in the moment. So to the extent that you buy the responses on EMAs a little bit more readily than one would either global question in a survey or even a location-specific question that might get youth focused a little bit more specifically on their behaviors at a given moment in the past week, one might place a little bit more stock in these EMA responses. Overall, the pattern, I would argue, is consistent, but here a little bit less evidence that Black youth are at risk with respect to the number of people around in the moment. All right, so with respect to home-based exposures, we ask, is the youth letting people who don't live with them inside the home? Do they have a high exposure caregiver? So this comes from a couple of different questions administered on the caregiver survey that try to get at both the occupation and level of contact with others. And then we use the proportion of EMAs answered at home as a proxy for time at home here. Ultimately, we would use the GPS data to capture that. And we used a combination of GPS data and then also a space-time budget that helped us clean that data to get those results I presented to you earlier on the youth spending time at home as a function of violence level in the neighborhood. We don't have the GPS data here, but we have EMAs that are randomly administered. It's not clear that they are randomly responded to, but nevertheless, it is a first cut on time at home using a proxy. So we want to look at racial differences here and then also racial differences across waves. So we can compare some of these questions to the wave 3, the just prior wave pattern, to see how things might be changing with respect to Black-white differences. Okay, so first is youth letting people who don't live with them inside the home. Agree, about 40%. Here, we see a slightly elevated Black coefficient, somewhat different, somewhat positive effect for Blacks, but again, no evidence of difference. All right, so with respect to family risk status, does the caregiver, caregiver's partner, or anyone else in the household work outside the home? That question is combined with, does that person come into close contact with others, never, rarely, sometimes, or often? So this is asked of each household member, so we know then whether the youth is exposed to either a caregiver or another member of the household who has a high-risk occupation. At least one person in the household is our measure, so a dichotomous measure of this risk. Okay, here we see no difference at all with respect to race in the likelihood of having at least one adult in the household or other person in the household who has this high risk exposure. It turns out that, and again, think about this as from the standpoint of the youth. What would explain the youth's racial disparities? From the standpoint of the youth, they are exposed to, Black and white youth are exposed to different numbers of adults in the household who might be eligible, who might have an opportunity to have this experience, in part because of single-parent house, disproportionate number of single-parent households within the Black population, employment status, and so on. This leads white youth to have essentially the same likelihood of exposure to essential worker who comes into close contact with others. Black caregivers are at higher risk of being an essential worker, but Black youth don't vary in their risk of encountering one in the household. All right, so here we look at probability of being at home, and we look both at the pandemic as well as the immediate pre-pandemic wave. And what we see here is that the COVID wave shows a somewhat elevated but not statistically significantly different likelihood of Blacks to report being at home on any given EMA response. What we see in the prior wave is a very small positive effect, not significant again. So essentially no difference, if anything, positive effect for Black youth. So there may be some, this is again very preliminary and we need the GPS data to corroborate this. But what we see here is some consistency, some pattern, possibly elevated pattern of staying at home, at least particularly when you look at the prior wave. The first wave, we see a pattern where Black youth are more likely to be at home. And some carry forward of that even through to the pandemic wave. There's a potential for Black youth to be spending somewhat more time at home than white youth. That difference may have increased. We will need more data to try to understand whether that's a meaningful change. In any event, there are no evidence that they're spending less time at home than white youth. We also have an EMA question on how many people are around in the moment. Here we look at the highest category on that EMA response. Are 11 or more people around at the time of the EMA? What we see here in wave 3 is a borderline significantly negative effect for Black youth, as they report lower likelihood of having 11 or more people around on any given EMA. And same negative pattern, although not significant, during the COVID wave. So Black youth also reporting fewer people around at a given moment. All right, so the overall pattern there then shows either no difference in protective measures and density of social exposures, or some tendency toward more lower risk exposures, more protective measures among Black youth. We think, again, these are highly preliminary data, but they do, to some extent, call into question the density of social exposure mechanism as an explanation for the racial disparity. Obviously, much more needs to be done on this. This does not preclude other aspects of exposure contributing to that racial disparity. For instance, the composition of social exposures. You could be exposed to fewer people, but they are themselves higher risk folks. And we just have difficulty measuring that, although I think there are some potentially interesting ways to get at that. So I want to just briefly refer to some of the work that's coming out of the project that captures this or speaks to the exposures to stressors and physiological stress outcomes by race as possible explanations for the racial disparity. So here we're talking about vulnerability to infection, say conditional on exposures. That vulnerability is greater for Black youth due to, and here we're focused on measures, biomeasures that tap into potential compromise of the immune system. So in work by Jody Ford, who is part of the AHDC team, she looks at salivary cortisol, which is measured in a subset of wave 1 kids, hair cortisol for capturing chronic stress, and this is one of the more innovative aspects of her work on the project, and then salivary Epstein-Barr virus DNA, and finds Black-white differences among the youth on all of those, indicating vulnerability for Black youth here, and notably for the hair cortisol, which is arguably the best measure of chronic stress. So we think that bears on possible racial disparities in infection risk in this population. As well, this is work that's forthcoming in psychoneuroendocrinology. We did an analysis of exposure to a police killing in the last 30 days based on interview and then immediate salivary cortisol data collection. And what we find here is that Black male youth are at elevated risk of higher cortisol, salivary cortisol, if they had been exposed to a police killing in the last 30 days. There were about 5 dates on which that occurred during the observation period. And so a distribution of killings across that roughly 13-month period. And we find evidence that salivary cortisol levels are elevated during the 30-day period after police killing for Black male youth in particular. So both of these then address the possibility that there are chronic stressors, ongoing, regular stressors Black youth face that have biological consequences that are potentially relevant for infection vulnerability that could explain their risk over and above social density of exposure. Now, this is certainly, we're not alone in this argument, and ultimately what I think is that we need to combine our focus on exposures to be somewhat more sophisticated or refined in our understanding of how exposures may be working, with potentially more emphasis on the composition of exposures, and maybe try to move beyond a sort of exclusive focus on these pure density-based measures to try to get at racial disparities in infection risk. And then bring in stressors and the stress consequences of navigating everyday life for Black youth and ultimately their interaction. It's probably the interaction where we are going to find the greatest leverage. So youth perhaps who have higher risk exposures and enhanced vulnerability due to stress are themselves going to be at greatest risk, and being able to home in on that set of kids will be, I think, most productive for trying to understand the racial disparity. So with that, I will put a slide up this research team. I'm deeply indebted to them. We have a bunch of great folks working on this project across multiple units at OSU and also UT Austin Statistics, my longtime collaborator, Kate Calder. Also special thanks to Jake Terrence, our graduate student in the OSU Sociology Department. Put a lot of time and effort into these analyses very quickly, so much appreciation for that. So thank you.